I'm Dr. David Baskin. I'm professor of neurosurgery here at Houston Methodist Hospital, the director of the residency training program, and also the director of the Kenneth R Brain Tumor Center. I'm here today to continue to talk to you about a new concept called oncomagnetics, the use of spinning fields to produce oscillating magnetic fields to kill cancer. In my previous talk, I discussed with you all of the basic research going from the Petri dish into animals, and now we're going to jump into humans. So we were very excited about the powerful effects that we saw in the cultures and also in animals. And so we went to the FDA and said, look, we'd really like to do this in patients. The FDA said, well, this is pretty preliminary. We usually only like you to treat end-stage patients, and what we'd like you to do is do something called expanded access compassionate use. So what does that mean? It means that if you have a patient who's failed all sorts of treatments, in this case it means radiation therapy, chemotherapy, in some cases gene therapy, in some cases a second dose of radiation, in some cases even different chemotherapy, and people at the end, nothing left to do, we're going to let you, case by case, try to treat these patients. I said, oh my gosh, that's a little difficult, because by then these tumors have become resistant to just about anything. But that was the opportunity we had, so we took it. And the idea we had in our minds was, well, at least maybe we can show it's safe, because we know it's safe. We've done lots of safety study in animals, and this would be an opportunity to do that. We really didn't think it was going to be very effective, but we thought we'd give it a shot. So this was our prototype design. One of my patients said, you know, it looks like I have 3 beer cans on my head, and I guess that's true. There's the third one. There's the third beer can over there. It's basically 3 magnets equally spaced, lots of calculations showing that the magnetism will cover the entire brain. And that's one of the challenges in glioblastoma. You know, we operate and resect a portion, but as you all know, these tumors are like an octopus. They have a head and they have fingers that go very long distances in the brain. So the idea with this design would be that we would be able to cover the entire brain with a powerful therapeutic treatment effect and hopefully make a difference. So this is our first patient. Very nice guy, patient of mine, had surgery, had radiation therapy, had chemotherapy. Tumor came back, he had surgery again. We injected gene therapy. He had another dose of radiation, and then he had a different chemotherapy, 2.5 years of lots of difficulty for him. And then the tumor came back again. The tumor came back in a way that it was in the fluid cavities of the brain, something called leptomeningeal disease. And so at this point, this median survival is 4 months. Very nice guy, very motivated. His wife was a physical therapist, understood medicine, so we entered him in as the first patient. What we saw, much to our surprise, is that within 30 days, there was a very significant shrinkage of the tumor. If you look at the tumor here versus here, it's much smaller. And if you do calculations, it was about 31% of the area of contrast enhancement went away in a month. So this is just a graphic illustration of the fact that within 30 days, we saw a pretty significant reduction of the tumor volume. However, tragedy struck. This man was involved in an accident, developed a closed head injury, and he died before we really had a chance to see the total power of this effect develop. His wife was very motivated, allowed us to do an autopsy. So here's his brain, and much to our surprise, this obviously was the area of the tumor. We did analysis of the rest of the brain. There was no evidence of any damage from the oncomagnetic therapy, but much to our additional surprise and delight, we saw something else. The area of the tumor had been replaced with calcified cells, fibrosis, and dead cells. We saw very few cancer cells at all. So yeah, there was a 31% reduction in the contrast enhancement, but it looked like a lot of that contrast enhancement was inflammatory response in reaction to the oncomagnetic treatment. So it looked like the effect was extremely powerful. This was our first patient. It inspired us to continue on. So this is a patient who's kind of a perfect storm of failure. He'd had surgery and radiation therapy. He'd failed that. He had previous squamous cell cancer of the tongue. He was the BRA2 positive, which, as you know, is that cancer gene that's so important in breast cancer where women have prophylactic mastectomies. He had, in addition to the regular chemotherapy, He had a different set of treatments. He had Lymphorza, another chemotherapy, Keytruda. He tried Optune, which didn't work. In addition to that, he had Crohn's disease. Crohn's disease is an inflammatory disease of the gut, and the treatment of that is immune suppressant therapy. So you can imagine if you have immune suppressant therapy, that's going to prevent the immune system from killing your cancer even more. So he was sort of a perfect storm of badness, unfortunately. A very nice guy. And he also had spread into the CSF pathways. But again, we were taking all comers, so we treated him. And what you see here is a rather dramatic response. He had no other treatment, and by day 157, the contrast enhancement is almost completely gone. Extremely powerful effect. Never thought this was going to be the case. In fact, he tolerated this treatment so well, he went back home and wore this helmet at home. We weren't even monitoring him here. This is a very interesting case study, and one that was discouraging, but then ultimately very encouraging. This is a 79-year-old woman. It's actually the mother of an ER doctor here at Houston Methodist who had glioblastoma. Same story. She had surgery, she had radiation, she had chemotherapy, failing all treatment. 79 years old, older people don't do as well with glioblastoma, kind of at the end of the line. So we started treatment, and here's a very interesting finding. At day 14, look what happened. It looked like the tumor was growing, going crazy. It looked like it was growing horribly fast, and indeed she developed a very severe weakness on the opposite side. I was like, oh my God, what are we going to do? Do we need to stop the treatment? Do we need to say this is no good? But then I remembered the animal studies. And remember in the animal studies that early on we saw a lot of swelling because the treatment's so powerful. As you kill the tumor, you get swelling and inflammation and it looks bad. So what we did is we lowered the treatment from 6 hours a day to 2 hours a day. 2 weeks later, her paralysis went away and the tumor is almost completely resolved, at least the contrast enhancing component. So this was very exciting because number one, it worked, but number two, it proved that this is a very powerful treatment. You know, and in some cases, even though only 6 hours a day is not very much, some people might need even less. So we did some scientific studies here. We did MRI spectroscopy, which, as many of you know, is a way to interrogate the molecular structures. And in glioblastoma, the choline to NAA ratio is an important indicator of tumor. The higher the ratio, the more likely there is tumor. And what we found is the choline NAA ratio dramatically decreased during treatment, indicating that we were killing tumor cells. And the other thing is we saw a lipid peak. So what are lipids? Lipids are part of the cell membrane. When you see a lipid peak, it means you're breaking up the cell membrane and killing cells. So using sophisticated interrogation of chemical signals, we were able to show that as these tumors were shrinking on the MRI, we were seeing the kind of cell death that we expected with the kind of chemical signatures that should be there. It's a very interesting patient. This is a young lady, 28 years old, who has a diffuse midline glioma, or sometimes called diffuse intrinsic pontine glioma. It has the molecular signature of H3K27. These are terrible tumors. They're brainstem gliomas that are refractory to all treatment. So she had surgery to remove the part that was sticking out. She had radiation, and then she recurred. She recurred with tumor in the ventricle. So the survival with this kind of situation is 4 months. She actually had spread to her spine at this point. We couldn't treat her spine, but we treated her brain. And what we saw over 276 days is this tumor completely went away. She wore the helmet. She was actually able to go to work. She put the helmet on in the morning before work. She put it on in lunchtime. She put it on into dinner. And for over a year, she was completely functional. So that's a triple survival. Then what happened is some of these tumors from the spine kept seeding up into the brain, and we kept killing them. We could see them kill, but eventually the tumor burden was so bad that about 2 years out, she passed away from the widespread tumors from the spine. But wow, this is a tumor that nothing works for. This is a survival of 4 months. We had a year of her wearing this helmet and going to work and enjoying life. And so this was also very encouraging. Now, this is very different therapy than other therapies that are out there. This is a helmet that has a neoprene lining You don't have to shave your head. You don't have to stick electrodes on your scalp. It's only 6 hours a day. Some of the other treatments are up to 20 hours a day. So that's one very important difference. The device uses spinning, oscillating magnetic fields, not electrical fields. Completely different technology than the other ones out there. We know how it works. It works through electron transport chain. It produces increased levels of reactive oxygen species, and it only kills cancer cells. Unlike other technologies, there's no dermatological effects, there's no skin irritation, there's no skin rashes, which so many of these patients get if you put something on their scalp because they've had radiation therapy once or twice. And finally, there's marked shrinkage pretty rapidly. So we have now developed a much smoother, slick version of this helmet. You can see it here, and you can kind of insert a magnet into the helmet, and you can recharge it. All you have is this little device that you can wear on your backpack or on your belt. And we've actually even done a compliance study. So if you have sleep apnea and you use CPAP, continuous positive airway pressure, Medicare wants to know if you're using it. So now these devices have a little chip that sends a signal that says, how often do you use it? So they know if you're compliant. So this device has the same thing. So if we do a clinical trial, we can actually tell when did the patient put the device on and when did they take it off. Important if you want to make sure the technology works. Another startling fact is we said, let's just try this in other cancers. So there's 3 other cancers that we know have high levels of reactive oxygen species: triple negative breast cancer, lung cancer, and pancreatic cancer. And guess what? In the dish, it works. It works very powerfully. So there's a lot more that we could do. We're focusing on glioblastoma now, but we anticipate trials with devices that will fit on various body parts to treat other cancers as well. So this is disruptive technology. You know, if I told you 10 years ago I can hack your refrigerator and turn it off, you'd tell me I'm crazy. Now everybody's worrying about it. So this is new technology. It's out of the box, and it's in the cycle of rethink, reimagine, reinvent, and disrupt. And I'm hoping this is going to disrupt the treatment of cancer. Imagine having cancer and not having to treat it with radiation therapy, chemotherapy. Wow, that would be disruptive. That would be as interesting as hacking your refrigerator. So the good news here is that we actually have reached out to a very reputable site in Germany, and we have a clinical trial ongoing right now. We've entered 3 patients. Obviously, it's too early to tell too much, but in one patient, we've seen very dramatic shrinkage over 4 weeks, at least indicating that we're off and running and we have something. We just met with the FDA yesterday to see if we can start a clinical trial in the United States. So we're really excited about taking something over 6 years from an idea in one's head to a petri dish to animals to a clinical trial. So thanks so much for your attention. The last illustration is a video that's going to review with you exactly how this works. It kind of goes over the things I've told you, but seeing it visually perhaps gives you even a better idea about what we're doing and how it works. Thanks so much for your attention.
At Houston Methodist, we've developed an experimental magnetic device that generates targeted oscillating frequencies and patterns that have been shown to destroy cancer cells. In normal, healthy glial cells, the mitochondria normally produce reactive oxygen species, or ROS, as a byproduct during normal function. Normal cells are prepared to handle the containment and elimination of ROS. However, cancer cells produce ROS at an increased rate due to their dysfunctional mitochondria and abnormal metabolism. Because of the increase in the creation of ROS and a lack of ability to manage it, the amount of ROS in cancer cells is naturally higher. The magnetic device takes advantage of this imbalance. The oscillating frequencies and patterns are focused and powerful enough to alter electron flow in the electron transport chain. When the electron transport chain is disrupted, this suppresses energy production in the cell. In addition, the perturbed transport chain electrons react with oxygen to create ROS. ROS opens the mitochondrial permeability transition pore in the mitochondrial membranes. This disrupts the homeostasis of the mitochondrial transmembrane potential and the integrity of the mitochondrial network. Signaling molecules cytochrome C and SMAC Diablo are also released as a consequence. They trigger a molecular cascade that leads to the activation of caspase 3, which definitively triggers apoptosis. The toxic contents released into the cytosol of the cell cause its lysis and its contents to be released into the surrounding area, leading to the progressive death of many nearby cancer cells.